Good morning and welcome to Scheller College of Business at Georgia Tech. My name is Maryam Alavi, Dean of the college, and I'm delighted that you could join us this morning. Today's program is the fifth session in the Digital Disruption series. The series explores digital trends and how technology can be leveraged by successful firms to create value and to basically train the workforce of the future. This morning's program is a collaboration between Scheller College, Accenture, and Anthem, and focuses on the topic of frictionless healthcare. So as most of us know and believe, healthcare is one of those industries that is going to touch every single one of us at a point in time in our lives. And I think probably one of the things that we can really agree upon is that healthcare is too costly and it's very hard to navigate. So to sort things out, we have a great program for you today. Of course, all of us know that cost is a key motivator for making changes and looking at ways to enhance and change and streamline healthcare industry. For example, in 2017, the estimates for the cost for healthcare in the US was $3.5 trillion. That translates to about $11,000 for each person. And there are estimates that if unchecked, the cost is going to rise to $6 trillion by 2027. And that would be roughly about 20% of the GDP. So one of the resources, one of the elements that are viewed as a possible way of reducing the cost while hopefully enhancing access and the quality of healthcare are this whole arena of digital technologies. And I'm really using the terminology very broadly. So all various types of hardware, software, techniques, data that could be brought to bear on enhancing the healthcare. So that said, there are lots of challenges that need to be addressed in this particular industry. To name a few, some of the regulatory and privacy issues. So to help us sort things out this morning, we will start with a panel of experts that are going to help us understand. They're going to define for us this concept of frictionless healthcare and discuss various aspects of this particular topic. And after the panel discussion that I will be moderating, we are fortunate to have two keynote presentations. Bob Kafuri of Accenture will discuss digital disruptions in healthcare. And his presentation is going to be followed by another presentation by Waris Bukhari from Anthem. His topic will be the near future of AI, artificial intelligence, in healthcare. I will now take just a few minutes to very briefly introduce our panelists. They are amazing and esteemed panel members that you have seen their bios, and you are aware of many of their accomplishments, either online or in the programs that were given to you. So I will keep my introductions very brief because I know you're here to listen to our panelists and to our keynote speakers, not here to listen to me talking about them. So in alphabetical order, the first panelist is Avery Ashby. Avery is the Managing Director of Applied Intelligence, Southern Market, Payer and Provider for Accenture. Having worked in payer and provider organizations his entire career, he is passionate about how analytics may enable change in people's health and improve their experience in the broader healthcare system. Next, we have Katie Baker. Katie is the Director of Innovation, Digital Care Delivery for Anthem. In this role, she is responsible for leading academic partnerships establishing a strategy and framework for intellectual property sourcing, and serving as a liaison for digital teams and universities. Next, we have Elizabeth Minot. She's one of our own. Beth is a distinguished professor in the College of Computing and the executive director for the Institute for People and Technology at Georgia Tech. In her research, Dr. Minot investigates the design and evaluation of health information technologies, including creating personalized mobile technology for breast cancer patients and evaluating mobile sensing and mHealth engagement for pediatric epilepsy patients and their caregivers. So panelists, please join me on the stage, and let's give them a warm Scheller College welcome. Okay, welcome again, and thank you for being here this morning. I will just ask a number of different questions, and as a protocol for our interaction, if I ask a question, let's say if I direct it to Avery, and somebody else has something interesting to add to that, please don't hesitate. Just jump in. So don't necessarily wait for me to call on you, okay? All right, so in healthcare industry, there are three primary stakeholders. Of course, there are patients and their caregivers. There are payers, and then there are providers. Three different major stakeholders. So let me start by asking each of you to define this concept of frictionless healthcare from various three stakeholders' perspective. So, Avery, I'm going to start with you and ask you, what does the term frictionless healthcare mean from a patient's perspective?
So, I think we've all experienced friction, try to leverage healthcare systems in the past, right? Yes. So I think it really has to do with removing non-value add steps and tasks in the process of seeking, receiving, or delivering care. So an example, just recently, my son was ill on the weekend, wanted to find, obviously, some care for him, urgent care. And where we live, we have a health system that has an urgent care search capability that also allows you to go ahead and put your name, in the queue. And so I was able to find the place that had the wait time that matched my drive time. So I was able to optimize and reduce or limit the amount of time that my child had to wait for care. So this is just one example where, previously you'd have to call around, they'd have to answer the phone, there'd have to be estimates on how long the wait would be. Is very inefficient. And so, that's just one example I think that hits home for me.
Great example. Beth, could you define the concept of frictionless healthcare from perspective of payers and healthcare providers?
All right, so I'll start with thinking of this in terms of healthcare providers, but payers are complicit or integrated into this.
Okay.
Because right now what we have is a system optimized for previous model of care, past century model of care. And as we want to create a frictionless system, we're looking to identify barriers as we have to tackle the cost that you were speaking of and the major demands on that system. So if we're removing the barriers to care, for me what that means is expanding the traditional model of the walls of the healthcare system. Just as you said, even having a network of urgent care, being able to extend out through technology into people's homes, into people's daily lives, and looking to how people, patients, but they're people the rest of the time, how people manage their health, and how do they engage the healthcare system in that way. So as we move to optimize to this new system, we're finding barriers in our siloed traditional model, and we have to figure out how to re-engineer around those barriers.
That's great. Katie, your thoughts on that?
Yeah, so I think a couple things. Both answers here I think are extremely relevant in the sense that I don't know that we actually can define frictionless healthcare yet. I think we can give examples of what it might mean. Is my mic working? No? Okay.
I can hear you fine.
I figured you could. Now, can you guys hear me? Yay! Okay, so what I said before was brilliant, and I'm sorry you missed it. So I was just saying that I'm not sure that we can actually define frictionless healthcare very well yet. I think we have some ideas of what it could look like. I was actually talking to a colleague of mine last night. Hello, Brent. And we were talking a little bit about Amazon and thinking about how could Amazon be replicated in a healthcare model, and how do you know what you need, or have a system that knows what you need before you know that you need it, and can bundle things together for you, maybe even perhaps create a subscription model for you that would allow you to be able to better take care of yourself. It would be more personalized, it would be preventative, and it would allow for more human-to-human interaction, which is really what we want between a provider and a patient, is that human-to-human interaction, so that we can really solve for the chronic or non-chronic conditions that they're experiencing.
Great. I'm really hoping that you can get there as fast as possible. The next question is, I'm going to ask the same question from three of you, the next question. And this has to do with we kind of started to talk about it a little bit, the benefits and challenges in healthcare or new models of healthcare. So Avery, what are some of the potential benefits of frictionless healthcare for patients and patient care? You did talk a little bit about that in terms of optimization and time saving in the example you gave us in relation to your child, but how can we generalize that? If we were to come up with some general categories of benefits to patients, what would some of those be?
I think what we're seeing is with the availability of new types of data, whether it's genomic or social determinant, and then some of the advanced analytic techniques, that we're able now to really start to think about what precision medicine can look like. And so from a friction perspective, as a patient, if I have to try lots of different treatments to really find the one that works for me, now by using more available information, we might be able to get there much faster. So as an example, the way that a person metabolizes medication is different. Some people can metabolize it very quickly. Some people, it'll last in their system longer. And so, we were building a model around trying to predict readmissions with people with COPD, and found that GERD, or chronic acid reflux, is one of the main contributors to that. And so when you dive into understand why that would show up as a signal for it, it's because people that metabolize the over-the-counter anti-reflux medicines quicker may have an exacerbation while they're sleeping that then interacts with their COPD and may cause them to go and seek medical treatment or emergency medical treatment. But there's a very simple surgery that can be done to those people that would benefit them to alleviate that. So I think my point is it's trying to move away from sort of one or two size fits all to really leverage new data to make sure that we can get more precise medicine to the people that need it.
Great example. Beth, what are your thoughts on that?
So I want to continue this thread because I want to look at both notions of healthcare being more personalized and being more holistic. So from a personalized perspective, continuing on with this of understanding that we've traditionally had, and even the notion of expertise in healthcare has started with a one size fits all, like this is the standard treatment of care, and then we kind of debug it with each patient very ineffectively. And especially when you're looking at issues such as chronic disease, where care may be episodic, or maybe you come in once a month with respect to some forms of treatment, or maybe even just once a year for something like asthma or epilepsy, that debugging cycle is horrendously slow. So what can we do with this? So moving to personalized care models allows us to use digital technology, analytic technology, mobile and home technologies, so that the person is feeling that they are getting the recommendations solely directed at them. The holistic care model also means that instead of only focusing on traditional healthcare challenges, that we also take into account every aspect of that person's life and integrate that. So, the Amazon example is not the person being required to go to the particular store, bricks and mortar store, and having to engage only with what they offer and how they offer it, but it's having this abundance and being able to structure those recommendations. So as an example, we've been working in Rome, Georgia, so a rural area of northwest Georgia, on treatment for breast cancer patients. And part of what we identified by this notion of removing friction was to work with cancer care navigators. These are precious human beings. Unfortunately, there's not enough of them, but their job is to figure out how to remove barriers to care. We studied what cancer navigators did and then took those practices and encapsulated those into digital tools so that when a patient comes in, they now get mobile technologies that takes all of that advice and all of that knowledge, and they bring that home with them. But then we use personalized and adaptive techniques that are based on their diagnosis and on their treatment path and then on patient-reported outcomes. So we're continually refining those recommendations to care. So they feel that instead of cancer care being located in a particular physical place with particular experts that are only available in certain times, they feel that they're always connected to their care and it's more personalized to them.
That's great. Comforting, very comforting for patients.
Very.
Katie, your thoughts on that?
Yeah. First of all, isn't that so cool? Like, that is so cool when you think about that. And in that same vein, thinking about how we can digitally deliver interventions and monitor people so that they are in, their own homes and they feel safe, but also being able to have access to things that they otherwise wouldn't have been able to have access to. Telemedicine is a huge part of that, relationship management tools for caseworkers and doctors. I think there's lots of benefits of frictionless healthcare, and even reducing the burden on the system as a whole will allow more quality care and allow us to think more about a whole person. If we can, reduce barriers on the whole systems from the ER to the ambulance and the first responders, all the way through the system, that eases that system for us. And some of it is even when you're thinking about like the records, for instance. How can we just something so simple, well, in theory, so simple, if we can reduce that barrier, I mean, what a huge benefit to the system as a whole. But I think that personalized and preventative and allowing people to feel that it's medicine for them, and that they're being heard and that they're being cared for is the biggest benefit.
So Beth, you talked about all these different ways that technology can really provide holistic and personalized care for patients. One of the challenges that immediately comes to my mind is this idea of issues around privacy and data security. All of that requires having a lot of detailed data about each individual in terms of their healthcare, their challenges, treatments, et cetera. In my mind, at least, I'm not sure if we are even close to addressing these issues around privacy and information privacy and security. If you have any thoughts about that to share, or where do you see this challenge, or where do you see potential solutions to that might be?
Certainly. So everything that we've talked about is about more and more information from the patients, from their care network, from their socioeconomic settings. And we run a real danger. I'm not going to talk about security as much. In some sense, we know how to do this. We just don't necessarily do it well in industry. But how we operationalize that data is really important. So one of the things that we have to watch out for is looking at what machine learning algorithms would predict in terms of certain forms of treatment, but then also understanding what data is layered into that. So, for example, it can be the case that different cancer treatments require different forms of burden on a patient and on their families. And you could use socioeconomic data that would be able to depict that this person is from a well-off family, they have a living spouse in the home with them, they have a robust network of care. Algorithmically, this person is probably a better case study for a higher burden treatment than someone who lives alone, who is still working, maybe doesn't have a great record with adherence to other treatments, and algorithmically will decide, well, this person should get a different treatment. That is something that happens with human bias in healthcare now. So this is not a new problem, but now we are encoding it into systems where that decision making may not even be apparent. And so you're a new physician, or you're a nurse navigator, and you're just getting the recommendations coming out of this system. You may not realize kind of all the variables that have been encoded. So as we take our existing systems, there are tremendous biases built into that data. There's tremendous human bias built into our existing practice, and we can actually create the worst of both worlds by combining those together instead of creating the best of both worlds. So we have to be very careful in understanding the assumptions that are laid into the work that we're doing now. And one of the things that I've been really impressed with is that a criteria for any machine learning algorithm is that you immediately assess it, so that the question is, do the most vulnerable in the system get essentially the highest opportunities, right? Can you run the system to see if people of certain races or certain socioeconomic conditions are being left out? You reject that algorithm, you rework it, and figure out what it's doing. So we have to push more on our data-centric approaches, that it's not just pure data or pure optimization, because we will actually exacerbate the deepest challenges we have in healthcare now.
So in fact, you identified yet another issue and challenge around data and analytics use. But again, having all that data, personally, I keep thinking, who has access to that data? How is it being protected? How is it going to be possibly monetized in different ways so they can now advertise to me? So there are lots of issues around data. It could be a very positive, powerful thing in a positive way, and it could kind of create all kinds of challenges. So let me turn to Avery and Katie now and see if I can get you to focus on the benefits and challenges of these new models and new ways of doing things for providers, because they play a key role in this whole scenario, as well as payers. So Avery, let me start with you.
Sure, and I just wanted to say, what you're describing is what we refer to as responsible AI, and making sure that the transparency and the auditability is available, right, to understand and make sure that the bias in the models aren't just being reflected due to the human biases that you described.
Exactly.
And so there's a whole approach that we have.
You get to talk
that.
about this a little later, so yeah.
But yeah, I mean, as far as payers, as an example, this is something I get really excited about as a statistician, and thinking about all the different deep learning models that are available now, convolutional neural networks that can look at images, whether 2D or 3D, and really help augment the physicians. So it's not something to replace doctors or nurses and their expertise, but really to help complement and supplement them. One of the biggest ways is that the machines can just continue to work, right? So they don't need to sleep, they don't need to eat, they're not going to be fatigued. So they can do things at scale that really help to make diagnosis more efficient and effective, those type of things. The other thing that we're seeing, especially on the payer side, when I speak to payer leadership, they often ask, how can we make our operations more efficient? Not particularly to reduce our FTEs or that sort of thing, but really things take a long time. Humans take a long time to do things. And so some of the solutions that we're building now are really pretty advanced, using graph technology, being able to do natural language processing to surface up information for a clinician to react to. And then the input from the human is then recorded and used to make the predictive models or the machine learning algorithms in the background learn over time. And so we found this to be a very effective, very cost savings type of solution that then allows capital to be used for other things, like lowering healthcare broadly, or investing in other kind of human-focused interventions like care management, some of the things that you guys are describing as well.
Great, Katie.
Much like Avery was saying, I mean, I think if done well and done right, we'll be able to provide a better service to our members. And, in theory, if we can reduce doctor time, ER visits, other things, we have a massive cost savings. So, I mean, it's a quite a clear benefit on the one hand for a payer's perspective, and thinking about like how can we impact and allow for a person to lead a healthier, happier life. Like that's a win-win for everyone. It makes a ton of sense.
Absolutely.
Greg. So we have already started to talk about technology, digitization, potential benefits of it in terms of how it can change services in healthcare. So let's dig a little deeper into that. And Avery, I kind of stop you from getting into a lot of ML kind of machine learning kind of thing, but just give us a better sense of, you have already given us a couple examples, but at least perhaps in the near future, what are some ways that technology can help us to make things better, less expensive, and more accessible?
Well, you know, I think it kind of goes back to some of the things we already talked about, right? Virtual care. So allowing, you know, people that live in rural areas to have access to, you know, to a very talented specialized physicians, whether it be cardiac care, et cetera. I think, you know, again, where we try to leverage the analytics and the machine type of automatic processes, it's going to proliferate throughout the whole healthcare system in a myriad of ways, right? So making sure that there's clear use cases that are being defined, so that once they're put in place, they can actually be evaluated to see if they are having the intended benefit or not, and be able to then, you know, pivot to something else or make some changes. It's not just a panacea that, you know, technology is going to fix everything. And frankly, you know, we were talking about social determinants of health. Sometimes you don't need a model to make an impact. Sometimes just knowing that someone can't go to the doctor due to travel restrictions or the inability to travel, you know, breaking down that barrier may be all they need to get the care that they deserve and that they, you know, have to have.
So
Can I come in on that?
please, absolutely.
Because I feel like we've spent a lot of time on the kind of the personalized aspect, but I'd like to push more on this notion of the holistic aspect and meeting people where they are and using technology to do that. So there's virtual models of care. There are ways of just meeting people at the point where they're making decisions that are relevant to their health. So some of the work that we've done with people with diabetes, you know, we can show that you're newly diagnosed with diabetes, you go into this class, so we've already now created a subset of people who are willing to take the class, but you go into the class and they can learn about kind of the book knowledge of diabetes. Do their habits change? No. Right? At best, maybe they follow the prescribed diet for a couple of weeks, and then they just very quickly assume previous habits. However, what we've seen is in the design of mobile technologies, which is just enough mobility, just enough AI, but increasing those touch points of care into the daily decision making, then people will start to work to changing their habits and their decisions. But they're in the grocery store trying to decide what to buy. They're in the restaurant trying to decide what to order. They're you know, at breakfast the next morning trying to figure out kind of the compromise between what the doctor has said and what they're willing to do. So if you can create that continuum of care through technology, through analytics, through virtual touch points, and the trick is they don't actually think they're interacting with the technology per se, they think they're interacting with their healthcare system through the technology. When you can create and mimic all of those touch points, then you start to change people's behavior, and then you start to change all the cost curves around this.
Really trying to figure out how do we understand the barriers, and then reduce the barriers and make the technology that's allowing for that invisible.
Yep.
So interesting, Beth, you started to get into the ways to influence behavior.
Yes.
And compliance of patients. And I happen to be married to a physician, and he always tells me these stories about how patients do not comply. They don't take their medication. I mean, as simple as that. And you know, the funny story he once shared with me was an elderly patient who had come with a niece to see him. A niece had brought her. And so my husband Henry asks the patient, are you taking your medication? And the patient, yes, of course. Are you taking it as I prescribed it? Yes, of course. And then the niece kind of goes behind the patient and keeps going, no, no. Which is really a funny situation, but you know, if they're not complying with medication and they're not open about that to the physician, and then the physician is saying, oh my God, this medication is not working, so I have to change it to a different one or increase the dosage, it creates all kinds of issues. So this concept of being able to influence behavior of the patients is really important. And how can we do that? Because unless people change their behavior, the outcomes are going to be the same and they're not going to be improved. So a great point. Katie, one of the things that you do in your role is partnerships with universities. So how do you see collaboration and partnership with universities is going to help us in this arena of new models of healthcare and making things better?
Love this question because I love my job. So yeah, I get the joy of working with universities daily to figure out how can we use technology to close some of the gaps that we might have. That could be, reducing, really reducing any gap that we might have, but the overall goal is to better serve the populations in which we're trying to help. So thinking about what are the gaps that we have, whether that be knowledge or talents or even the intellectual property, and figuring out how can we partner with universities to best fill those gaps. So it could be partnering on studies, it could be publishing partners for policy change, IP, sponsored research, all sorts of different ways, but I really view our academic partnerships as an extension of our Anthem family in really allowing us to push faster, harder, and deliver products that make a difference in people's lives as quickly as we can because it's so desperately needed. Because to your points, right now healthcare it's very antiquated in a lot of ways. And so if we can almost leapfrog where we're at right now to be able to make a super huge impact, I think without universities, I don't think we would be able to do that.
That's great.
Do I get
Beth,
to chime in? I have to chime in.
I knew. Beth, do you have any thoughts on that?
This is where I get to brag about our Georgia Tech students because it's just so phenomenal to have student innovation to be part of this equation. And so just some great examples of the things that are happening here. So first is, the touch points with how technologies are changing our experience of health in daily life. So some of the work that has come out of Georgia Tech and others has looked at the role and influence of social media technologies on mental health. And to be blunt, my engagements with the healthcare system, for example, just really had a blinders on with respect to understanding how social media technologies were exacerbating mental health, especially around eating disorders and some of the work that we were doing. And I was talking to clinicians and they're like, yeah, funny, because when they're in our waiting room, they're constantly connected to those devices, but not understanding the impact that they would have. And so that came out of our students working actually with high school students to look at how these technologies were framing and actually creating a new normalization in their minds around the role of and attitudes around eating disorders. So that was one example. We're doing amazing work in virtual reality where you're able to simulate the experience of providing healthcare. So an extreme example, but people who are working in, for example, an Ebola ward are not quite as scary, but we're getting there with the coronavirus, which is we train public health workers practically with PowerPoint. And so we tell them how to do their job, and then you put them in a stressful situation, they quit the first day, right? They're out of there. Well, that is not effective models of care, but we're creating virtual reality environments that actually generate that stress. We're simulating body fluids, we're simulating everything, but people are then actually trained for what that situation is going to be like. And then finally, looking at new mobile technologies, new home technologies, bringing in industrial design, bringing in psychology, really having that multidisciplinary perspective, because we're asking people to carry technologies with them, to wear technologies. We're asking them to have them in their homes, to interact with them in public spaces. That's not just a medicine problem, that's a design challenge. And being able to bring together the psychology and the design and the engineering to make that happen is just, there's such a wealth of talent at our universities. So I will stop bragging about how great our students are.
Well done, thank you. I think the whole issue is not a point-to-point solutions, it's that holistic approach. Just like the treatment needs to be holistic for the patient, these kind of solutions needs to be holistic.
Yeah, just one point on that. When you think about, if you have gut health issues and you go to a GI, so many of them now are looking at your mental health because if you're nervous, if you're stressed, if you're whatever it may be, causes so many physiological, outputs of that. Like you're really, so they have to look at a whole self.
Absolutely. Avery, I want to have you focus on the economic impacts, the business models of all of these potential changes and new ways of doing things. Again, if you take it, or you can take any of the perspectives, the payers, the providers, the patients, the cost issues. You know, we are all hoping that the cost will be reduced, but who's going to lose, who's going to gain, how's it going to work out?
That's the big question, I think, right? You know, what we've seen is that you have to have a strategy around implementing digital solutions in the healthcare space that include ways to pay for as well as ways to realize value after they're in place. So I think a lot, you know, we can look at things like, you know, the movement over to data lakes as an example, not particularly healthcare related, but healthcare related in the sense that these large companies with all these data are looking for, you know, simple places to put it. A lot of people went in that direction, and now they're struggling to actually get value out of them, right? Just as a you know, at an individual level, you know, if I'm able to optimize my time, like my example of going to the urgent care, that to me creates a stickiness with that healthcare system. So now I want when I have choices, I want to, you know, use them again, right? So their investment in a digital solution that helped me get care that I needed more efficiently makes me want to be, you know, sort of their patient longer term. I think healthcare plans in general have a really negative, no offense, I used to work for several of them, have a pretty negative sort of connotation when people think about, you know, I don't want them contacting me, I just want, you know, to be able to go see a doctor and have my claims paid, those sorts of things. Very, very low net promoter scores. We're seeing quite a bit invest in sort of omni-channel digital type of customer relation management. And what that does is it allows them to be seen and really to be thought of as other consumer type companies like a Verizon or someone else that has a very good customer relation management system. So that's just easy, right? People want easy. People don't want to wait. And so just because it's healthcare doesn't mean that those expectations change. And so there are ways to build out those capabilities and realize the value while increasing the satisfaction of the patient, member, or consumer experience that I think there's ways to find those balances so they offset one another.
So as I'm listening to you talk, we have ways of approaching this problem. We have different ideas about how to reduce the barriers, how do you be more holistic, how do you be more personalized in terms of delivery of medicine. So we have great ideas of how to move forward. What are we waiting for? What is the real barrier for making these changes in healthcare? I mean, we have, these are, you heard so many examples of great solutions, right? Great ways of approaching this. And I have heard this for many years. My field is in digitization, my own field of study. So that has been one of the industries that probably starting 20 years ago, everyone looked at technology and said, oh, this is going to bend the curve and make all the differences. It really hasn't, or not at the speed, or not at the scale that we hope it would by now. What's going on? Why is it? What is the real barrier of making these changes? Any thoughts, ideas?
We have, I think it's always been described as perverse incentives in the healthcare space. So, so some of the times, for example, when we've been working with healthcare systems and here's my app and it's going to help people better manage chemo treatment and it will help them keep them out of the ER. All right. Almost everyone can nod their heads that that is a good idea, except for the people who make the money out of the ER, the budget arena, right? It's like if my technologies keep people out of the traditional system, somebody loses dollars associated with that. So that is the challenge, which is where I started with at the beginning with respect to frictionless healthcare, is that we have a beautifully optimized, outdated system. Right. And right now we're kind of throwing different technologies and different approaches and some analytics and some telehealth, But if we're kind of just throwing things into an existing system, the system is pretty robust to rejecting those
Yes,
from an economic model point of view. And so what we're slowly starting to see, at least in my 20 plus years of this, is we're going from the one-off points, and then when we're evaluating partnerships, we're actually looking at partners that can take a system approach, because they have to look at the business model, the technology model, the patient touch model. You know, who is paying for those home technologies? Who is paying for those virtual visits? How are we taking advantage of the fact that less revenue is here, but more revenue is there? So you have to look for partners, and you have to look for folks who are willing to elevate it to the system level approach. Otherwise, you just feel like you're just throwing things against a brick wall.
Which, by the way, it seems to be one of the major issues for a lot of large, major, successful organizations in different industries, because they all want to change and transform and innovate. It is not one element and one piece. The system is truly optimized for doing what it's being done in terms of the outcome. Right. For example, if you go see your doctors, even if you have an appointment, what happens? First of all, they tell you to come in at 15 minutes earlier. Okay, so you show up 15 minutes earlier, and you end up waiting 45 minutes because the system is optimized for the providers, so they can run from one room to the next and don't waste, in their minds, a minute. So it's really a reconceptualization, redesign of processes, procedures, business model, and by that I mean the economic incentives and economic models. And when you are dealing with such a mammoth industry that is so well designed and traditional, the idea of changing it by little tweaks here and there is just not going to happen. And
it has to be truly disruptive.
It truly has to be disruptive. That's why when you hear places like Google or Amazon kind of starting to think about this healthcare issue, it's interesting, because maybe they can come up with something that is truly disruptive. So at this point, it looks like the changes, all these opportunities, are not as much about technology per se. That's a tool. Mm-hmm. It's cultural. It's existing system. It's fragmentation of care, the way it exists. Katie, you talked about this issue that, the GI person looks at this. Healthcare is really fragmented, not only in terms of systems that exist, but also in terms of specialties. When you go to a GI, that's all they look at. I mean, you may have a real issue that is causing different things. No, they're focused on that. How many times you have gone to your doctor's office, maybe a big, great healthcare provider system, and you go from one doctor's office, they give you these little tablets now, right? They want your information. You fill it in. Maybe 3 months later, you go in to see a different specialty in the same system. You get the tablet again one more time. Could you input your system? And say, I just did this. It's the same organization. So fragmentation is another real challenge. Great opportunities. So let me perhaps end. I want to make sure we allowed enough time for interaction and questions. Was there any question that you wished I asked but I didn't?
You had a question about what were the potential dangers to patients, mm-hmm. and we took it around a data security, machine learning analytics way, but I think there's actually some just more fundamental dangers that I worry about. So when we take an existing system and then we want to, disrupt it or re-optimize it, we don't tend to always look at the secondary benefits in the existing system, and we tend to obviate those. So for example, one version that we're looking at also in cancer care is as you move to pill-based, pharmaceutical-based for chemo as opposed to coming in for chemo treatment. So you can get highly optimized care, you're creating a particular prescription and someone's taking it at home, they don't even have to come into the chemo center. It sounds perfect, right? What we have done is underestimated the value of that social support care within the chemo center and the people that are encouraging them and that are meeting them every time, even interacting with other patients. And we've taken that huge social support system and left a person sitting by themselves in their kitchen staring at a bottle of pills that makes them feel bad. And we already know that people don't take their medication.
Yeah.
And just because you're going into cancer treatment doesn't mean you're even any better at that. We're also taking systems that are, again, around social networks of care and then saying, okay, here's an app for you. An app is a solitary type of experience. You know, you set your goals and you do all of this and you figure out how to make yourself better. That works with certain socioeconomic groups. It fails horribly with others, right? Community-based approaches, network of care-based approaches, social-based approaches. So we tend to take out the sociality that actually is part of what magically is making healthcare work, and we don't see it. And then when we digitize, we remove that out of the system. So I worry a lot and fight back and forth a bunch on understanding that human approach, those social connections, the social connections of the network of care. Let's not eliminate those in our rush to create technical individual approaches.
Sounds great.
Very good
Katie,
point.
did you have?
Not necessarily a question that you didn't ask, but when I think about the last question that you asked about what are the true barriers, while I completely agree the system as a whole needs to be disrupted, as you were saying, and we have to build something new while maintaining something that we have, that's a challenge,
Real
right?
challenge.
Right.
Like that's
Big
really
challenge.
hard.
Very expensive challenge.
It's true, yeah. But how do you make that transition happen?
Right.
But even within that, like thinking very pragmatically, you know, when you think about just like FDA trials, for instance, it's one thing if you have a drug and you know the compound isn't going to change. When you have a digital intervention and you can tune an algorithm, what does that look like after you've made another tweak? What does that trial look like?
Right,
What are those constant approvals look like? And really, I know that you're saying that digital has been around for a long time, and it has kind of in theory, but in practice, it's not. And so we don't have a lot of those things in place that we need to be able to advance medicine as quickly as we want to.
Great point, and of course we can see that in all the other fields. You know, this whole issue around the autonomous car. If something goes wrong, who's responsible?
Yep.
So again, so it's not only the existing systems of healthcare delivery that needs to be disrupted, laws, regulations, and a whole policies around a lot of things. So I think the magnitude, just a few things, few small things, yes. I think, so prime example of how technologies are moving faster from human systems across the board, policy, regulations, everything, incentives. So a lot of interesting challenges, a lot of interesting dissertation topics for our students, Beth. So let me stop here and see if there are any questions that the audience has. Do we have mics running around? Okay, so please raise your hand high so they can bring you the mic. Carrie?
Hey guys, Julie Fry. Thank you guys so much for doing this. This is awesome. One of the things I was curious about, you guys talked a lot about major future improvements and disruption on ways you can, and thinking like maybe 5 or 10 years down the road with your roadmap. But one of the points that Avery had mentioned was saying people right now would like things easy. I mean, which I would agree. And then also mentioned, you know, it is hard for healthcare providers to get a good rap since so many issues. So just kind of curious, what are you guys doing to help people today? And an example might be referrals. So if people have HMOs, especially if they've gone on the marketplace and had to go buy stuff, a lot of those are HMOs where you've got to deal with referrals. So referrals might take 15 days to happen. So insurance companies are then dealing with people that have gone with a minor issue, maybe the day it's realized that they have to get a referral, to 2 to 3 weeks later before they can even get a referral for it approved. So not only then is the insurance company potentially spending more on an issue, helping the person, but the person has soft and hard costs, saying, I've got to pay more for an issue that's developed over the course of 3 weeks, and I might be missing work, I might be missing kids play, things like that. So I was just kind of curious, how is the industry actually working on today's issues?
So I'll take, so just to preface, so I think people trust their doctors and their nurses, right? They're frustrated at access challenges, of course. The healthcare payer side, for whatever reason, sort of has that can sometimes have a more difficult.
Be nice,
I'm
Avery.
trying
Come
to.
on.
Yeah.
Sorry. But I mean, to your point, right? So you bring up the challenges with this sort of holistic aspect of healthcare, right? You have network differences between different plans, right? People choose one plan because maybe it's more affordable than another, but then they have restrictions on being able to go directly to a specialist like in an HMO, rather than being able to do that in a PPO plan, right? I think if the reason that it takes so long to get from your PCP to a specialist has to do with lack of information around who is available, right, within a particular area. So instead of having to go to this specific physician with this specific specialty, there might be 5 or 6 others within a reasonable range that could see you sooner. And so if those dots aren't being connected, then that's something that either the health system or the health payer has to be able to solve. Now, certainly there's ways of doing that using data and algorithms and that sort of thing, as well as portals that you can log into as a patient and be able to do your scheduling and those type of things. But it really is dependent on where you live and what options you have in terms of the coverage that you can get from your health plan.
I can chime in a little bit too. So at Anthem, we have, and I hear what you're saying, a lot of the stuff that we're talking is 5-10 years out still. We do have, for instance, like an app today called Sydney Care that if you don't have it downloaded, anyone can, member or not, insured or not, but you can start to type in or put in your inputs for your conditions yourselves, and then we can start saying, here's what other people with your same conditions have experienced. Would you like to learn more about those? Then start referring doctors and things like that so you can get a little bit more personalized care on that level. But beyond that, we have on our digital team, so we have Anthem Digital. On our digital team, we have people that are thinking about things that are 5 and 10 years out. And then we have things that are thinking about things, my team, for instance, is thinking about 0 to 3 years out. So we're really thinking about, like, how can we take the technology that is available today? While we're trying to seed technologies that will be available in the future, what are the technologies that are available today that we could deliver upon in the next year to help reduce some of those barriers for people and allow for digital interventions to be easier delivered?
Okay.
Hi, my name is Conrad Merritt. I'm the CEO of a software company. I have to give Scheller College a plug. I got my MBA from this school. It's the best investment you can make. So if you're thinking about joining, I promise you.
Thank you, and please do say this was not planted. Okay?
It was not. It's not. I got my MBA in 2003, so I'm not telling my age though. But about several weeks ago, I met with the commissioner, one commissioner of the FCC, Jeffrey Stokes. I also met with Congressman Hank Johnson and Congresswoman Lucy McBeth. They came to Georgia talking about some of the challenges we have, especially you're talking about a 5G network coming as well. It's not fully there yet, but they talk about the disruption of technology because they're trying to reduce the latency as well, especially in the rural areas in Georgia as well. How do we get this technology out there? What can the FCC do as well, or Congress can do particularly when it comes to healthcare, as we see a lot of consolidations as well. So they're trying to figure out what can we do, not just from latency because of security too as well. We spoke about security, but getting the best health care to people out there. And they spoke about the millennials. Nobody wants to go to the doctor's office and spend 2-3 hours. We want the doctors to come to us from our home as well. So those are some of the challenges we want to find. Can you tell your perspective? What do you foresee? How do you find to maximize 5G as to be part of this disruption?
So I think it'd be interesting to reflect on this from an economic development perspective. And this is one of the challenges with healthcare is such a large market that it tends to play by itself, right? as opposed to taking a community-based approach and saying, access to 5G, access to these technologies in our community, they're important for health, they're important for education, they're important for bringing jobs, they're important for the overall vitality of the community. How do we actually bring this together? Because you're critically right. We can have all of the innovations within these digital technologies, but if you don't even have access to that infrastructure, what good is it for you? But it also is very difficult to say, okay, healthcare is going to pay for all of this. Our school systems are going to pay for all of this. Our major employers are going to pay for all this. So how do we create state initiatives where, we understand the importance of transportation, at least a little, with respect to planning for the future of our cities and our state. But we need to actually understand the next layers of technology. There's actually some beautiful similarities between planning the internet and planning our network highway system. Some of the same people were involved in those blueprints. So we're going to have to take this at an economic development argument, but partner with the large providers, partner with the payers. But then, one of the best things that has come out of this is employers say, for us to be able to attract future businesses, we have to have good healthcare and we have to have good education. Focus on that equation and work to make it happen in our communities.
I think the other part of it is when we talk about infrastructure, a lot of people think about the traditional roads and highways. Yep. I think we need to think about infrastructure, the physical and then the digital one, and they really impact each other and they interplay. So it's an issue looking into the future. People should not plan these differently. I mean, they really need to come together. They're intertwined. So that's another thing that we need to look at in terms of who the designers are and the design issue. Okay. Any other questions? There's one in the middle and one in here.
Hi, Erin Anton, recent graduate of the Scheller MBA program. Also have to speak praises to it. Fragmentation in this industry is actually incredibly profitable, and horizontal integration is very difficult, time-consuming, and expensive. And that's part of the reason why we have over 1,000 EHRs, right? So I'm curious what technologies or groups or pathways you've seen that are really exciting you, that are bringing together a lot of the industry and helping to drive that disruption.
Smart graduates.
Yeah, you can lead the charge. Again, if a system exists already and is profitable, as you suggest, we should not expect the system on its own disrupt itself, right? The incentives don't allow that. That's why I made a comment that when you see places like Amazon and was it Google that are kind of thinking about this space, I think the disruptions are going to come external to the existing situation. So that's probably the only way that I see it happening.
Please go.
I was going to say, I have one example. Sorry about that. I have one example of something that I can think about that is across all platforms, and that's when I was talking a little bit about those records before. So a lot of people, Anthem included, we're moving our health records to FHIR, which I know that's fairly new. It's a standardization of record. It would allow for everyone to have access to the same record. That, I think, is going to help reduce so many barriers for physicians, even me, when I think about like getting access to my own children's records, is so challenging. Like, this should not be this hard, and this is really challenging. So something like that, I really do think is going to make a big difference.
So there are interoperability, such as FHIR and other types of open platform approaches that are enabling this. Again, one story, but when we started doing this tablet work with our cancer app, the first inclination by the healthcare system was to lock it down. Like, it wasn't an open platform because, oh my goodness, somebody might go onto the internet and look for healthcare information. And we had to remind the doctors they're doing that already. Locking down a platform that you're providing is not going to prevent people from working around it. But if you opened it up as a platform, then it could have value for other uses, which made it intrinsically an important investment as opposed to just a cancer investment by the patients. And then you got prolonged use. So this notion of how do you create open platforms that these technologies, and this is why the partnerships with the Amazon and Google and such are helpful, because they're not thinking of this as, you know, it's just about this particular treatment or just about this particular healthcare scenario. It's an engagement with, thank goodness we haven't said the word consumer yet, but it's an engagement with people in their everyday lives.
Very good.
And, you know, I would, when you think about like Cerner, right, or Epic as an example, and HL7 and the fire standard, you know, part of it has to do with just our natural inclination to be competitive, right? We live in a capitalist society. And so over the last several years, you've seen major investments by Cerner and Epic to really be the end-all, be-all for the health provider, right? So everything from predictive modeling, right, algorithms that are presented when someone is admitted to a hospital, all the electronic medical records, being able to create their own data models and data warehouses, right, so that people can use them for analytics and reporting, et cetera. And so by creating all of those type of capabilities in a single entity has really prevented, I think, you know, to your point, the availability of other things to plug into it, because they hold the keys to the kingdom. Mm-hmm. I remember building, you know, multiple predictive models, and it was so hard to be able to operationalize them into a production system like a Cerner or an Epic because you couldn't access it, right? Mm-hmm. And so that I don't think that'll particularly change anytime soon. Because it's all about market share and it's all about, you know, delivering value to their clients. So definitely hear you. I think that there are going to be major, you know, disruptors. We were talking about it last week at another meeting about where the private equity is spending its money, right? And so you're seeing these small startups that are taking a holistic approach that's built on technology first, as opposed to trying to retrofit technology in, as you were describing this morning before we started, into their old systems, and it's just really hard to get that compatibility.
Yeah, and I think that's an issue that, again, a lot of large corporations, a lot of other industries, they have made millions of dollars of investments in these systems. Of course they're going to defend it. Of course they're going to open it to everybody. So it's, again, the incentives issue. Okay. A couple more questions.
Oh, and then we had the gentleman in the middle as well.
Yeah, but
Yeah.
I'll just yell.
okay.
Yeah. So a lot of what we've heard, I think, has been primarily with the lens of the U.S. healthcare system. I'm curious if you've seen anything on a global perspective that you either find really interesting or anything that you've considered bringing back to the U.S., just any innovation that you've seen on the global scale.
I don't know if any. I don't know if any.
I mean, I think the biggest difference between our healthcare system and, you know, we were hearing it all over the news, right, with Bernie and other candidates is, you know, single payer or, you know, government-run healthcare, right? So in many other countries, they don't have the types of challenges that we have here because it is more, for better or worse, it's more consolidated. Now, of course, there's benefits and there's pros and cons to everything. You know, as you're describing, can I get access to the doctor I need instead of having to wait? You know, the same thing happens other places as well. But that's one of the biggest differences that we see. I do think, and we're actively working on many projects. Joe Deppa is leading some, and I know, you know, others like you are involved as well, where we're actually trying to break down the barriers globally and bring data together from the various other countries that are doing similar research that, you know, that our country is on these chronic illnesses or cancers, et cetera. And so by using, you know, a global familiar type of standard, we're able to be able to get higher numbers, right, of records and people to study that hopefully will lead to cures or at least treatments faster. So we see an opening of the globe in that perspective.
Just a quick add to this, I think it's around having an outcome-centric model as opposed to a treatment-centric model. And so what you're starting to see is other disruptions in the US system that are playing with that in different ways. One of the advantages of the cost to employers is employers are moving to engagements that are outcome-centric as opposed to treatment-centric. And they're doing that more in preventative and health and wellness. I would also, I need to plug a new program that we're working with Emory Healthcare around older adults diagnosed with mild cognitive impairment. And this is a holistic model that is around diet and exercise and compensatory strategies. And it's not around the pharmaceutical-based treatment of Alzheimer's, but it's around everything that patients and their families can do to slow the progression of the disease. That's very outcome-centric, and so that is a huge experimental program that is shifting in that direction. So you see the experimentation with that, and then the question is how do you integrate that into the system while the plane is still flying in a traditional model?
Well, I can add one more thing. Brent wants to add too. Just when we talk about records, so to do a lot of these interventions that we're working on, we need to have access to as many records as we can. If you're trying to tune algorithms and try to do predictive models and things like that, the more access, and Anthem has a lot of access to those records.
Yeah, you can't complain about that.
We cannot. But when you think about partnering with other countries, Israel is a huge partner for us. We have an Anthem office there, and when you think about their system, their healthcare, they have every record of every single person that lives there. So you see a lot of startup companies in the health and wellness space that are coming out of Israel, and they've been really strong partners for us.
MD Clone is one.
Yeah.
And
Yeah.
Yep.
Great. You had your hand up. Yeah. No. We are trying to go with a sequence if we can keep track of it.
Thank you for taking the time to come talk to us. I also am a recent graduate of the school, and nobody put me up to this.
Welcome
It's
back.
a great investment.
Like that's,
Welcome back.
That's amazing, right?
He says, and you still came back. Of course.
Of course, I
Welcome
know.
back.
Yeah, awesome. So in my mind, the stuff we've been talking about, the reducing the barriers and seeing having a holistic approach to healthcare. In my mind, I kind of categorize them as attacking micro issues, and I'm thinking more at the macro level, like big trends, especially in the U.S. I'm just asking about if you've seen any example of the algorithms that you've spoken of and the different technology applied to solve these problems. And a few of them that I'm thinking about is a growing number of adults, parents, are choosing not to vaccinate their kids. And healthcare is being inaccessible to a huge chunk of the population. And the opioid crisis, things like that. Are your technology being applied anywhere to curtail those issues?
So I think some of the things that we're looking at, so I will argue with you about the cost of chronic disease and shifting people's behavior not being a micro issue, but we can do that later. But I think what I've been really interested in seeing is the increased innovation and rapid pace around mental health. So I'm going to put that in terms of the opioid crisis, in terms of other, we've been looking at PTSD, actually using Georgia Tech as a laboratory because one of the mental health crises in our country is actually with our young people and mental health on our college campuses. And so to understand algorithmically and technology-wise how we can essentially create new diagnostic tools and new ways of understanding what is happening in those settings. You're still trying to look at ways of then finding interventions that would work within that space. But part of this is that we know is that if we can create better monitoring within these situations, that you can create early interventions, and sometimes those are very much community-based interventions or social network interventions that allow to intercept someone before they reach a point of crisis. Creating new algorithmic approaches that actually understand, are able to predict a new crisis, some folks were looking at work around bipolar and other mental health disease. So in that case, we actually have, and we'll talk about privacy when we pick this back up again, but there are a lot of pieces of information that are currently out there that if we can figure out the right sensing technologies and algorithmic approaches, we can get ahead of it with a predictive model. Now, once we can do the prediction, then what are we able to do to intervene effectively? So that is in progress, but I think it is a possible sea change, has massive privacy cultural implications to this as well.
I think when it comes to things like mental health, other forms of chronic illness, episodic delivery of care is not as effective. When things really go back, it's a continuous process, right. And these technologies and these approaches enable us to deliver care that these ailments need on a continuous basis. Let's see, one more question, please.
Former Scheller graduate again.
Ah, perfect. Welcome back home again.
Fundraising during the break. Okay.
Yeah.
And I'm with IBM now, so from that perspective, I attest to what Accenture does. My question really is, and piggybacking on what Ms. Alavi asked earlier, I see the three of you as someone who is a thought leader, someone who implements what is told, and Ms. Katie there as someone who will probably lead the industry in the disruption that we talked about. And one technology that comes to my mind is blockchain. I think that really is, and talking about records, privacy, everything, and ecosystems. I mean, we are talking about multiple ecosystems here. And of course, the peripheral things about analytics and apps and those kind of things, holistic versus the personalized, all of that. But my question is, who will really lead the charge? That's really the question coming back to. Who will, aside from the federal government or our government structures or the laws like HIPAA and all of that, who in the industry is going to step up? Like blockchain is a good example. Clearly, it has tremendous value. Just to your records thing that you mentioned. So,
I mean, good question. I don't know. I'll say us, but I don't know. I mean, I think everyone's working towards that as quickly as possible, but I don't have an answer for you.
I think
I'm sorry.
No,
well, aside from Anthem, who's going to lead the charge, but perhaps this is an area that some of the non-traditional corporations that have not been in this space could come in as a disruptor. Some of the startups, someone talked about the venture capital that is now being invested in this particular arena. Maybe it will come from overseas. Maybe all the amazing things that might be happening in Israel is going to help us. But the probability of it coming from existing successful players in this industry is pretty low. That's my guess, my opinion.
And I think one of the areas, the segments that I would like to point out to is the aging market, right? So the US has an employee-based healthcare system as our dominant system. But if you hadn't noticed, people are living longer, and people are grappling with a whole host of healthcare conditions within that. That is one of the areas where these non-traditional players are trying to understand what type of direct-to-consumer, direct-to-natural occurring retirement communities, home builders are looking at this. So there's a lot of disruption that is looking at that demographic market because it's not locked down in the traditional employee-based healthcare system. There are Medicaid, Medicare types of resources within that, but you're going to expect to see the disruption coming first from industry and then the federal programs trying to figure out what to do with it.
And that's a real good point because that antibody of rejecting or resisting new models does not, it's an open space.
It's a much more open space.
So one can innovate, start brand new. Okay, so in the interest of time, please give a thank you to our great panelists. We are now taking a break till about 10:30. So please step out and be back here around 10:30 for our keynotes. Thank you.